All right, it's almost 2 p.m., so let's get started. Good afternoon, all. I'm Dr. Aditya Agnimotri, Secretary of the KCIAPM, and I'm happy to welcome you to this new set of KCIAPM slide seminar for the year 2025. For the Jan session, which was actually postponed, and the live session is happening in February. I invite you all to this first ever slide seminar for this year, and it will be conducted by Neuberg Anand Reference Laboratory, Bangalore. Partnering is with us for this year's slide seminar are two industry partners. First being Sysmex, which is coming in as our platform sponsors, and and OptraScan, which is coming in as our digital scanning partners for this particular year. I'm sure you're experiencing their slides, and they're considerably improved from what it was initially, and the platform appears smooth now. With this, I would like to invite Dr. Anita Mukesh from Neuberg Anand Reference Laboratory to take over the proceedings and conduct the entire slide seminar. Over to you.
Good afternoon, everyone. I welcome you all for this afternoon session of KCIAPM slide seminar. We'll start off with the first case.
Good afternoon, all. Is it audible, sir? Is it audible, ma'am?
Yes, you're audible. Screen is seen. Go ahead.
Good afternoon, all. I'm Dr. Manju Alex, final year postgraduate from Sri Devraj Aris Medical College, Kolar, and I'm allotted spotter 1. The histories of a 40-year-old female, conventional pap smear has been enclosed. On scanner view, the conventional pap smear is adequate for interpretation, and junctional component is present in the form of squamous metaplastic cells. And we can also see dense inflammation and polyball formation, and pus cells, plenty are seen per hyper field. On hyper view, we can see pear-shaped trophozoites with flagella. Here, multiple trophozoites we can see here. And we can also see the pale, small, eccentrically placed nucleus. On hyper view, we can see cocobacilli, and individual squamous cells are also studded with the cocobacilli. Clue cells are seen. Summary: conventional pap smear is adequate for interpretation. Junctional component is present in the form of squamous metaplastic cells. Pus cells, plenty per hyper field, and pear-shaped trophozoites with flagella with small eccentrically placed nucleus morphologically resembling Trichomonas vaginalis. Also identified cocobacilli with clue cells. Diagnosis is negative for intraepithelial lesion or malignancy with Trichomonas vaginalis infection and bacterial vaginitis. Thank you, sir.
Thank you. That was Dr. Manju Alex from Sri Devaraja's Medical College, postgraduate student. Dr. Anita, I'm over to you for discussion. Dr. Anita, if you can hear me, I think we request you to unmute and share your screen for the discussion.
That was a nice presentation.
Thank you, ma'am.
Can you tell me what is the adequacy? How do you assess an adequacy of smear, Manju?
8,000 to 12,000, ma'am, on conventional pap smear. On conventional pap smear, 8,000 to 12,000, ma'am.
On LBC?
5,000, ma'am. 5,000.
Okay. How do you assess cells on the smear? How do you tell it is adequate? How do you count
Ma'am,
cells?
we should first of all see But the squamous cells are present, ma'am, and we should see if it is obscured by hemorrhage.
Okay.
And 8,000 cells, we should check, ma'am.
Yeah, correct. Okay. For status, generally we follow the Bethesda system, right? So in Bethesda system, first thing you have to tell whether it is satisfactory or unsatisfactory. For satisfactory,
Yes, ma'am.
you need in conventional, as you told, at least minimum how many cells? 8,000 to
8,000 to
12,000. 12,000. In an LBC,
yes,
minimum 5,000 cells.
5,000
So
cells.
to assess that, when you put the slide under the microscope, you have to see minimum 5 to 10 cells per hyper field, so that then overall count you get around 60,000 6,000 cells per hyper field. That will be how you
Okay.
assess. So when you call it unsatisfactory.
We call it unsatisfactory, ma'am, when the 80% of the smear is obscured by hemorrhage or
Okay.
hemorrhage or inflammatory cells, and we are not able to make out the squamous cells. And
Okay.
if it is, if even if one cluster of atypical cells are there, we'll consider it satisfactory, ma'am, even though if
Okay.
this is present.
Okay. Pre-analytical. Is there any pre-analytical cause where you can call it unsatisfactory?
Unsatisfactory. I don't know, ma'am.
So whenever the slide is broken or it is not labeled,
Yes, ma'am.
okay, you can call it unsatisfactory. And the criteria for specimen adequacy is a conventional, as you told, 8,000 to 12,000 well preserved cells. In a liquid paid pap smear, around 5,000 cells. You have to see endocervical cells, at least 10 well preserved endocervical cells or squamous metaplastic cells. If at all there is a high grade carcinoma, you can't, if though the cellularity is low, you can't tell it is inadequate. So it is still an adequate smear. Especially in postmenopausal women, if you are seeing less than 2,000 also, you can follow with pap smear. Okay.
Okay, ma'am.
Next, for unsatisfactory smears, whenever the slide is broken or there is the slide's particulars are not mentioned, you call them unsatisfactory smears. As you told, it could be obscured by hemorrhage or such smears also, you can call it as unsatisfactory smears. But if at all there is a malignancy and there is unsatisfactory smear, you still can't call it as unsatisfactory.
Okay, ma'am.
Uh, Now, using Bethesda system, how do you want to classify your smear as?
Ma'am, first NILM we can call it, ma'am,
Okay.
first. Then
Uh,
ATP of determined significance. Sorry, ma'am. Atypical squamous cells under squamous cell abnormality, and that is epithelial cell abnormality and glandular cell abnormality. We can divide it into, ma'am. And
okay.
under epithelial cell abnormality, we can divide it into atypical squamous cells of undetermined significance. Atypical squamous cells cannot exclude HCIL, low-grade squamous intraepithelial lesion or LCIL, high-grade squamous
Okay.
intraepithelial lesion or HCIL, and then squamous cell
Mhm.
carcinoma, ma'am. Under
So
gland
your present smear, how do you want to put it under Bethesda system?
NILM, ma'am, with
Okay.
it is yes, ma'am. Negative for intraepithelial
Allowance,
lesion or malignancy with trichomonas vaginalis infection and bacterial vaginitis, ma'am.
you want to include reactive changes?
Yes, ma'am. Few squamous cells are showing reactive changes, ma'am.
So whenever you're putting it under Bethesda system, you have to put it under reactive changes.
Hello, ma'am.
Just a second. I think some issue with the internet there. She'll be joining.
Hello? You can hear me?
Yes,
Yes,
ma'am.
ma'am, you're audible.
Okay. So what else? These were the DDs what we received. That was Trichomonas vaginalis being the most common one, followed by Ascus and Hask H. The tricho will have it will show a lot of changes in the pap smear. So the epithelial cells will show a lot of cytoplasmic eosinophilia, which can be mistaken for a squamous cell carcinoma or an ASCH or ascus. But you have to carefully look for these organisms to rule out these conditions. So the final diagnosis is what type of smear, that is a conventional smear, whether it is adequate or not adequate, whether the transformation zone elements are present or not present, and an NILM. If at all there is any other lesion, you can advise ancillary testing like HPV in these cases. Okay, the mimics what can be the degenerated cells in the background can also mimic like trichomonas. You should always identify the nuclei in the trichomonas so that you can confidently call it as trichomonas vaginalis. So majority of the lesions are in the reactive zone. So it is important to identify this spectrum of lesions. Thank you. I'll come to the first spotter. Identify this person.
Papinico. George Papinico.
Correct. Can
Now
you
to
move on to the
present, sorry. If there's any queries, please put it in the chat box, or you may even ask questions in the chat box. If there are none, I think I'll invite Dr. Riya Raj from Father Muller Medical College to share the screen
Yes,
and
sir.
present.
Sir, is it visible, sir? Hello, sir.
Yeah, go ahead, start.
So, I'll be presenting the spotter number two. Myself, I'm Dr. Riya Raj. I'm a final year postgraduate from Father Muller Medical College, Bangalore. The history given was 36-year-old female patient with a growth in the posterior wall of the bladder. In the lower view, what we can appreciate is the normal urothelial lining can be seen, and muscularis propria is seen, and after the muscularis propria layer, we can appreciate a tumor. In the higher magnification, we can see the tumor cells that are interspersed with the blood vessels. When we see the individual tumor cells, these individual tumor cells are arranged in nests or also called a cell balance pattern with dilated blood vessels in between. The involvement of the tumor cells into the muscularis propria can also be seen in this picture. When we see the individual tumor cells, these are epithelioid cells with abundant eosinophilic granular cytoplasm with round to ovoid nucleus, and it is having salt and pepper chromatin, and the mitotic activity is very less. Along with the irregular nests and the cell balance pattern, we can also see the pseudonocyte pattern, that is the arrangement of the tumor cells around the blood vessels can also be appreciated. So along with the chief cells that we have mentioned before, we can also see little elongated cells towards the periphery of the cell nest, which is also known as the sustentacular cells. This also shows the arrangement of the cells in nests separated by thin fibrovascular septa, and also capillaries in between can be appreciated. So, coming to the summary, we have seen the normal bladder tissue in which we have appreciated an unencapsulated tumor in which the arrangement of cells is mainly in nests, that is also known as the cell balance pattern. Along with that, pseudo-rosette pattern was also seen. The individual cells are epithelioid cells with abundant eosinophilic granular cytoplasm, round to ovoid nuclei, salt and pepper chromatid. Numerous dilated blood vessels with low mitotic activity was also identified within the tumor cells. Uh, Tumor cell nests are separated by the thin fibrovascular septum. With all the features, I would like to come to a diagnosis of paraganglioma of the urinary bladder. And depending upon the features I'm going to tell, it can be divided into well differentiated, moderate, and poorly differentiated. It is grading system for adrenal pheochromocytoma and paraganglioma based on the pattern of arrangement of tumor cells, cellularity, capsular or vascular invasion, comedonecrosis, MIB1 immunoreactivity, types of catecholamines produced. The differential diagnosis that can be considered in this case is the first one is granular cell tumor. But in the granular cell tumor, the vascularity will not be as high as we have seen in this case. Invasive urothelial cell carcinoma also will not be having increased vascularity. Along with that, the granularity of the cells also will not be appreciated. Well differentiated neuroendocrine tumor also, the cells will be monotonous with the granularity comparatively less as compared to the cells that we have seen now. That's all. Thank you.
Ria,
Yes,
nice
ma'am.
presentation. Yeah.
Thank you, ma'am.
They are requested to stop sharing the screen.
Yes, sir.
Okay. As already described by Ria, this case is a 36-year-old female with growth in the posterior wall of the bladder. And you can see the bladder tissue with a normal urothelial lining. And the tumor is arranged in nest or Zellballen pattern with abundant eosinophilic cytoplasm surrounded by fibrovascular septae. And the tumor cells are seen infiltrating the muscularis propria. So the nuclei are relatively bland. It is they have a central round nuclei with powdery chromatin, and occasional pleomorphic cells were seen. But overall, the mitosis ATP, there was no ATPia, mitosis was not there, and there's no necrosis. So the differential diagnosis we thought were paraganglioma, neuroendocrine tumor, invasive urothelial carcinoma, and granular cell tumor. We also got responses saying it would be a PCOMA. Now, yeah, why do you think it is not? Ria has already explained why she does not think it is an invasive urothelial carcinoma, because the cells appear relatively bland. There is no mitosis or atypia, and the overlying urothelial lining looks normal. And a granular cell tumor will be less vascular, and PCOMA will have a characteristic radial or perivascular distribution of the cells, which is not seen in our case. So going forward, what IHC would you like to do, Ria?
We can do synaptophysin chromogranin CD56, and it will be these all will be positive, ma'am, and negative for keratin, and S100 and SOX10 will be positive for the sustentacular cells, ma'am.
Yeah, very good. Thank you. So we went ahead and did chromogranin and synaptophysin, which was diffusely positive. And S100 showed positivity for sustentacular cells, and CK was negative. So our diagnosis is a paraganglioma of the urinary bladder. Now these tumors constitute less than 0.05% of bladder tumors and are derived from the paraganglial cells in the bladder wall. Now 40% are hereditary in adults, and most of the cases in children are hereditary, and 10% behave malignant, that is, they metastasize. And subsets with succinate dehydrogenase mutations are most commonly malignant. And even though there are various grading criteria based on necrosis, ATP, and mitosis, size, site, etc., there is no definite. The strongest genetic prognosticator is the SDHB mutation. So we went ahead and did IHC for SDHB, and it showed granular cytoplasmic staining, which means that SDHB is retained in our case. And the prognosis is local recurrence can occur with incomplete excision, and metastasis is the only reliable criteria for malignancy. Thank you. I'll go to the next quarter. Yeah. Can you identify this? 55-year-old male, raised lesions over the skin.
Request to respond in the chat box. Even the participants can respond in the chat. Request all PGs to respond in the chat box, and the presenters can actually unmute themselves and share the response.
Okay, I'll go to the next slide. So what is the etiology? Is it a viral or a bacterial? Anyone has responded? Yes. Rajeshri.
What is it?
Yeah. So I think it is molluscum contagiosum. So what is the etiology? Yes, it is viral. Which is the virus that causes it? Yes, Sneha. Yeah, it is a double-stranded DNA pox virus or molluscum contagiosum virus. And what are these inclusions called? The eosinophilic inclusions that you see? Can you write the full form? HP. What does HP stand for?
Shalini Krishnapriya. Yes, Nagavalli.
Nagavalli. Yes. Yes. Thank you. It is. They are called Henderson-Patterson bodies. Okay. So they are eosinophilic inclusions seen intracytoplasmic eosinophilic inclusions in the keratinocytes. They contain the viral particles. Yeah. Thank you.
Thank you. With that, we'll move to the next case, S3. I request Dr. Jeenu Jayan from Gadag Institute of Medical Sciences to unmute and share a screen. Dr. Jeenu, over to you.
Yes, sir. Hello, sir.
Go ahead. It sounds good.
Myself, Dr. Jeenu JJ. I'm here to present Spotter 3. I'm second year postgraduate student from Gadag Institute of Medical Sciences. The case details given to me is a 34-year-old female with urethral diverticulum and 3 slides were infused. This is slide number 1 on low power. It is showing many cystically dilated spaces lined by epithelium, and the subepithelium shows numerous inflammatory infiltrates along with muscle bundles. And on further increase in power, the epithelium is lined by a layer of cuboidal epithelium, and at some places, hope needling is also noted. And subepithelium shows many inflammatory infiltrates comprising of lymphocyte, plasma cells, and eosinophil, and many proliferating capillary-sized blood vessels. This on further increase in power, again the cuboidal epithelium noted. Along with that, the subepithelium shows many capillary-sized proliferating blood vessels, inflammatory infiltrates comprising of lymphocyte, plasma cells, eosinophils. This is another focus of slide number 1 in 10x showing muscle bundles with areas of fibrosis and inflammation. On further increase in power, a concentrically lamellated intracytoplasmic inclusion, basophilic inclusion, probably suggestive of Michaelis-Goodman bodies noted. This is another focus of slide number 1 showing tubular formation and few cystically dilated glands. These tubules are lined by thick basement membrane and lined by cuboidal epithelium, or a few tubules are lined by flattened epithelium. And in the lumen shows myxoid material. It is suggestive of nephrogenic metaplasia. Previously, it is called nephrogenic adenoma. And this is slide number 2 on low power shows cystically dilated space lined by epithelium with subepithelial inflammatory infiltrates and muscle bundle. Along with that, many proliferating capillary sized blood vessels and areas of hemorrhage noted. This is slide number 2, other focus showing cystically dilated space lined by urothelium, and in the lamina propria shows epithelial cell nest, which is also called worn bread nest, and in the subepithelium shows many inflammatory infiltrates with areas of hemorrhage and dilated blood vessels. In the subepithelial space, there is cystically dilated structures which is lined by urothelium and cyst in the center, and which is suggestive of urethritis cystica. And again, in the lamina propria, one cell nests are noted. Along with that, inflammatory infiltrates and areas of hemorrhage noted. This is slide number 3. One focus showing many muscle bundles, along with that inflammatory infiltrates and many proliferating blood vessels seen. This is another focus on of same slide number 3, showing inflammatory infiltrates predominantly of lymphocyte eosinophils, many proliferating blood vessels, and many foamy macrophages also noted. This is another focus of slide number 3, showing nephrogenic metaplasia. And in one side, there is a very concentrically lamellated basophilic inclusion, probably suggestive of Michaelis Goodman body noted. So I came up with differential diagnosis. My one diagnosis is differential diagnosis. One is malacoplakia and another one is urethral caruncle. So malacoplakia is the appearance of multiple nodular thickening of the mucosa and underlying stroma, and it is most commonly associated with immune deficiency states in the renal transplant and most commonly seen in renal transplant recipient. Grossly, mostly it is a solitary or confluent yellow nodule or plaque, and histologically it has abundant eosinophilic or amphophilic cytoplasm. Along with that, round or oval inclusions called Michaelis Goodman bodies or calcospherite also. The closest DD of malacoplakia is granulomatous inflammation, where Michaelis Goodman body is noted. Urethral caruncle, it is a small muscle protruding from the meatus, and it occurs mostly in the female urethra. And clinical feature mostly present as a painful and associated with hematuria. And histologically, the caruncles most resemble that of small hemangiomas, often associated with intense and chronic inflammatory cellular infiltrate. So point towards and point against these two conditions are in menacoplakia. In the smear, few bodies probably suggest of Michaelis Goodman bodies noted. Along with that, many forming macrophages, inflammatory infiltrates comprising of plasma cells, histiocytes noted. In a urethral caruncle, in the above slides, vascular proliferation is prominent, along with the transition epithelial hyperplasia with stromal fibrosis noted. Markers for nephrogenic metaplasia, cytokeratin 7, MECR, PAX2 and 8, and GATA3 positive, and it is negative for NKX3. And urethritis glandularis or urethritis cystitis is positive for CK7. And this Michaelis Goodman body, it is positive for PAS. Thank you.
Thank you, Dr. Jeenu Jain. What other stains would you like to do for the Michaelis-Guttman bodies?
Ma'am, Prussian blue, ma'am. Pass or Prussian blue. That will stain for iron, and Boncosa will stain for calcium, ma'am. It is a iron and calcium mixed material, ma'am.
Do you find any sheets of histiocytic aggregates in the section?
In some places, I have noted, ma'am, sheets of histiocytic aggregates.
For the arterial diagnosis, let's get to the discussion. It's a 34-year female. Clinical diagnosis given provided was urethral diverticulum. So the tissue fragments shows urothelial lining with mixed inflammatory cell infiltrate. But one of the sections, foci, shows these on high power. See, there are small caliber to medium sized tubules, and there are cystically dilated tubules like tubulocystic appearance. And all these glands were supported by a thick basement membrane. The background stroma shows some of the singly lined cells within the lumen, which might misdiagnose as signatoring cells and all. But this is a classic morphological feature of nephrogenic adenoma, as you had described it. But the differentials what we had received were, along with nephrogenic adenoma, malakoplakia, cystitis glandularis, and urothelial carcinoma has been received. So urothelial carcinoma we can exclude because there is no double lining. More than one lining should be there, and kind of atypia should be there. Nothing is there in this section. And cystitis cystica glandularis should show a mucoid kind of cells. Intestinal or mucoid kind of cells should be seen. Those are not appreciated in this. And as you had explained, malakoplakia, there are no definitive sheets of cells. Histiocytic aggregates were not seen. So the diagnosis was diverticulum with nephrogenic adenoma. And you're right. So this is a non-neoplastic lesion which has a propensity for recurrence. It is asymptomatic and incidental finding, and they usually occur as a metaplastic process associated with any secondary urothelial injuries, post-surgery, calculi, trauma, catheterization, or urinary tract infections. And good number of cases are noted with prior renal transplant patients, where the etiology is like seedling of these injured renal tubular cells. They uh, arrange at the injured area, and they can be associated with urothelial carcinoma, where intravascular therapy they had taken, or NSAIDs, diverticulum, and interstitial cystitis, and malakoplakia can be an associated finding, but in this case there is no malakoplakia. It's nephrogenic adenoma. So what all other patterns you can see in nephrogenic adenoma?
Ma'am, papillary pattern will be seen. Ma'am, tubules will be seen, tubular pattern.
Yeah, so the classic one, what we had seen, like tubules, and the confluent arrangement of the same tubules might look on a low power like sheets, but there are another patterns like cystically dilated area, cysts, classic cysts, micropapillary, papillary, and some might appear like solid areas of clear cells. Thank you.
Thank you, ma'am.
Coming to the next spotter, this is a 30-year-old female, biopsy from the nasal cavity. What is your diagnosis? What is a causative organism? No, it's not rhinosporidiosis, rhinoscleroma. Condition is rhinoscleroma. The organism causing is Klebsiella rhinoscleromatosis. And those cells, what we see, are called Meckel's cells containing bacteria, which are gram-negative Klebsiella.
Right. To present S4, I now invite Dr. Kirti from Nenapoya Medical College to unmute and share your screen.
Yes, sir. Am I audible, sir? Am I audible, sir?
Dr. Kirti, any issues?
No, sir.
Go
So,
ahead.
good afternoon, everyone. I'm Dr. Kirti, final year postgraduate from Yenagoya Medical College. The case allotted to us is S4. So, the history provided was it was a 51-year-old female with right ovarian mass, which is partially solid and cystic and measuring around 8 into 6 centimeter. So we have got two virtual slides. The first one, in the scanner view, you can see four cyst wall-like structure. In the 4x, the cyst wall is one side, it is lined by an epithelium. In the higher power, this epithelium is stratified squamous epithelium with some keratinous material, and the subepithelial stroma, which is fibrocollagenous, and a few congested blood vessels also seen. The second slide, the scanner view, you can see a viable area as well as a necrotic area. In the viable area, in 4x, you can see some cells which is arranged in diffuse solid sheets. In low power, these cells are in the low power, these cells are round to polygonal, few are epithelioid, which exhibit moderate to marked anisonucleosis. So these pleomorphic bizarre cells has vesicular nucleus with abundant eosinophilic cytoplasm. And some cells are showing intracytoplasmic brown color pigment which looks like melanin. Here you can see the melanin pigment. In the higher power, these cells has a prominent cherry red nucleoli, and also this geographic necrotic area is also seen. To summarize the findings, there was a cyst lined by a stratified squamous epithelium, and lumen was filled with keratin material. And the second slide, which has an epithelial cells which is arranged in diffuse solid pattern, and those cells are pleomorphic and bizarre with vesicular nuclei, and these cells were having prominent cherry red macronucleoli and abundant eosinophilic cytoplasm. Mitosis were sparse, and there was intracytoplasmic melanin pigment, and geographic necrosis was also identified. But there was no ovarian tissue identified in the both the slides. So, with all the findings, the diagnosis is malignant melanoma arising from monodermal teratoma. We suggest IHC for the further correlation. Thank you.
Okay, Dr. Keith. So, 51 years female with ovarian mass, solid and cystic lesion. As you had described, these are
Dr. Kirti,
epithelioid.
request you to stop sharing your screen once.
Yes.
So, yes. Please go ahead.
Yeah, from the solid area, uh, the cells are epithelioid and highly pleomorphic, vesicular nucleus with prominent eosinophilic nucleoli and melanin pigment is seen. And the cystic area shows this stratified squamous epithelial lining. This case, so the diagnosis what we received were malignant melanoma, mature cystic teratoma with malignant melanoma transformation and metastatic deposits. The final diagnosis was malignant melanoma and mature cystic teratoma of the ovary. We couldn't appreciate or identify the transformation like intraepidermal junctional activity, which has to be identified to call it as primary arising from a teratoma. But the other criterias of major criterias which were proposed by Boughton, like it is an unilateral mass associated with ovarian teratoma, there is a lack of extra ovarian melanoma. We couldn't follow up with this patient uh, to look for the any primary other than the lesion. But she is an postmenopausal female with gradual increase in the size with heavy abdominal contents. So intraepidermal junctional activity is not appreciated, and this there might be the probability of malignant transformation of this mature teratoma. So it's a worst complication and an uncommon complication. The most common one is SCC, which accounts for about 80%, then followed by adenocarcinoma, carcinoid tumors, and melanoma, which accounts for only 0.2 to 0.3%. The primary ovarian malignancy has to be excluded by asserting and identifying is there any metastasis from the cutaneous melanomas. Coming to the spotter, 10 years, 10 months child with a massive hepatosplenomegaly. This is a liver core biopsy. Can you identify these cells? Yes, Shruti, Gaucher cells. Thank you.
Request Dr. Ashita Fernandez from St. John's Medical College to take over and present S5.
Yes, sir.
Ashita, just quickly open your PowerPoint. Open your
Yes,
PowerPoint.
sir.
Elements?
So can
Yes,
you hear me, sir?
slide share. Enable editing and click on slide share.
Am I audible?
Yes, you're audible, Ashrita.
Yeah. Good afternoon. My name is Ashrita Fernandez. I'm from St. John's Medical College, Bangalore. The case given to me was case S5. The history provided was a 38-year-old male, sinonasal mass. So over here you can see polypoidal fragments of a neoplastic tissue composed of compactly arranged tubular glands. These glands were arranged in back-to-back manner with very little intervening stroma. The glands were lined by cuboidal to columnar cells, and the cytoplasm was clear. So coming to the pathological points, these are polypoidal fragments with compactly arranged back-to-back proliferation of tubular glands. The glands are lined by columnar to cuboidal cells with clear cytoplasm, monomorphic small nucleus, and inconspicuous nucleoli. Perineural or lymphovascular invasion, necrosis, or severe pleomorphism were not seen. So my diagnosis was non-intestinal type sinonasal adenocarcinoma, renal cell-like. Thank you.
Thank you, Ashrita, for the presentation. Yeah, so Ashrita has described very nicely. You see a polypoidal tissue composed of closely packed glands which have a clear cell morphology. They are lined by, so here you can see there is a squamous metaplastic lining over the polyp,
And the glands are lined by cuboidal to columnar cells having a clear cytoplasm, and the nuclei is small, round, and bland. And the NC ratio is very low, and there are some eosinophilic secretions, and the stroma shows areas of hemorrhage and vascularity. Okay, this is the hyper showing the same. So there is no necrosis, no mitosis, or atypia. So because of the clear cell morphology, our first differential diagnosis was a metastasis of renal cell carcinoma or a sinonasal RCC-like adenocarcinoma. So we have got multiple responses, including respiratory epithelial adenomatoid hamartoma, which would usually be a glands lined by ciliated columnar epithelium, and it will have mucinous change, which is not seen in this case. Then seromucinous hematoma. These are similar to microglandular adenosis of the breast. They'll have small glands, small eosinophilic glands, and does not look like our case. Then one response was sinonasal inverted papilloma. So they will have endophytic growth, and the epithelium would be squamous, respiratory, or transitional. So it does not match with our case. And the response is sinonasal intestinal type adenocarcinoma. So clearly there is no, the pattern will be tubopapillary, and there will be mitosis and atypia if it's an intestinal type adenocarcinoma, and definitely it does not resemble the same. And one more response was a tall cell carcinoma with reverse polarity, and this is seen usually in the breast, and it is eosinophilic and solid and circumscribed mass. But here we are seeing clear cell morphology, and the glands are in tubules. Right. So our main DDs are metastasis of renal cell carcinoma and a sinonasal RCC-like adenocarcinoma. So what IHC would you like to do, Ashita?
Ma'am, CK7, P, pancytokeratin and S100.
What will be?
C,
So
CK, yes.
to rule out metastasis from renal cell carcinoma, anything? Any IHC marker?
CD10 will be positive and CA9 will be positive in metastatic clear cell renal cell carcinoma, ma'am. But CK7 will be negative.
Okay. Okay. So these are the markers that we have done: CA9, CK7, S100, CD10, and PAX8. Okay. CA9 showed patchy membrane positivity, and CK7 was strongly positive. Right. And S100 was patchy positive, PAX8 was negative, and CD10 was negative. So PAX8, CD10 being negative rules out a metastatic renal cell carcinoma. And the literature says sinonasal RCC like adenocarcinoma can show variable positivity with S100, but they are CK7 positive. So based on this IHC markers, we have come to a diagnosis of sinonasal RCC-like adenocarcinoma. It's a very rare tumor and a recently described subtype of non-intestinal adenocarcinoma in the WHO 5th edition. And the treatment is surgical excision of the tumor with adjuvant radiotherapy. And this is a low-grade neoplasm. There are no perineural invasion, lymphovascular invasion, necrosis, or pleomorphism. Prognosis is good, and there are no recurrence or metastasis in any of the cases described. Yeah. Thank you.
Thank you, ma'am. As we discussed earlier, we will now. Do you want to share? Do you have a spotter now?
No spotter. We can go to the next case.
D1.
Yes.
D1.
D1, right? Yeah, okay. So we will take the hemat cases at the end, and we will go ahead with D1. That will be presented by Dr. Mehta Dhalip from JJ Medical College, Davangere. Dr. Mehta, if you're there.
Am I audible?
Yes, I request you to unmute and share your screen and go ahead with the presentation.
Am I audible now?
Yes, you're audible.
Yes. Sir, my presentation is visible.
Yes, please go ahead.
Good afternoon. Myself, Dr. Mehta from JJ Medical College, Davangere, will be presenting discussion case 1. History being 48-year-old female, right tonsillar hypertrophy, MRI, enlarged right palatine tonsils with lobulated margins, isointense on T1 and hyperintense on T2, 3.2 into 2.2 into 2.2 centimeters, heterogeneously enhancing on contrast, causing mild mass effect, enlarged bilateral level 2 nodes, 14 into 10 mm. Two slides were enclosed. Section studied from the given tissue bits shows a surface lining of stratified squamous epithelium. The underlying subepithelial tissue reveals a dense aggregates of chronic inflammatory cell infiltrates, predominantly lymphocytes. The lymphoid tissue is organized into nodules, well-formed nodules with well-formed germinal centers. Within these backgrounds, there is proliferation of neoplastic tumor cells, which are arranged in fascicular and bold pattern. These tumor cells are oval to spindle shaped with tapering ends, having scant cytoplasm, round to oval nuclei, and dispersed chromatin. The nucleoli appears indistinct. Few cells exhibit nuclear pseudo-inclusions. Multinucleated tumor cells are noted in certain areas. These tumor cells are interspersed with sprinkled lymphocytes, and few congested blood vessels are also seen within the stroma. My differentials are follicular dendritic cell sarcoma and interdigitating dendritic cell sarcoma. The histomorphological features are more inclining towards FTCS. Those are the median age of the patient being 50 years, median age in FTCS being 50 years, the patient is 48 years old. FDCS is more common in extranodal sites such as tonsils, whereas IDSC it is less common in extranodal sites. The histopathological features of FDCS like tumor cells in fascicles and storiform pattern, spindle to ovoid tumor cells sprinkled with small lymphocytes are also seen here, and pseudonuclear inclusions also seen. Whereas in IDSC, spindle to epithelioid cells in long interdigitating patterns are seen, which I was not able to see in the case. The positive stains for follicular dendritic cell sarcoma are most sensitive markers clustrin, CD21, CXCL13, and most specific FDC markers that are CXCL13, CD21, 23, and 35. Thank you.
Thank you, Dr. Mehta. Just a minute. Enter screen. Great. Can you see my screen now?
Yes.
Great. Yeah, thank you for your presentation. You're spot on. And your description of the morphology was very good. So this is...
Thank you, ma'am.
Yeah, can you just put on that? Oh, I think it's gotten logged out. Right. So you've got, you described reactive lymphoid aggregates in the subepithelium. What could that be that you were seeing?
Ma'am, the small lymphocytes I could
Yes,
see
that was
in the
within the
subepithelium
tumor.
and chronic
But you
inflammatory.
started off your description saying that there are reactive lymphoid aggregates within the epithelium and then there is tumor. So what are those reactive lymphoid aggregates? What's the site of this biopsy?
The normal tonsillar,
It's a normal tonsil, right?
sir,
So you can
ma'am,
say that.
right? Yes,
So
yes,
that's
ma'am,
the
normal.
normal tonsil that you're seeing, which is infiltrated by tumor.
Yes, ma'am.
Was the overlying? Okay,
Yes,
so
ma'am.
so what is the most common thing that you would think of at this site? It's a tumor. It's malignant. So what is it that you would think of? Because both of your differentials are very rare. Is there anything else practically that you would want to exclude in this site before you consider both of these entities? Although I admit the histology is quite characteristic, but still, for discussion's sake. Like on
Ma'am,
a
any
day,
metastasis?
more than metastasis, if you would get a biopsy from the tonsil query malignancy, what would you, before you put the slide on, what would you think, oh, this could be this? Maybe a carcinoma, squamous cell carcinoma?
Yes, ma'am. Yes,
So
ma'am.
that would be the common thing that you would want to exclude first. What is one point here that you could give
that you did not think of SCC? Why would you not think of an SCC here?
Ma'am, because the spindle cells, they were
Okay, what about
in,
sarcomatoid change
they
in
were
SCC?
arranged in,
Suppose I tell you this is sarcomatoid SCC, how would you counter and tell me no, it isn't? Is there any other point that you could get?
ma'am, no squamous hyperplasia was there, ma'am.
Squamous metaplasia or
Squamous,
what? Dysplasia? Dysplasia or
ma'am,
metaplasia?
dysplasia.
Dysplasia, right? Because this is normal squamous epithelium. So there was no
Yes,
dysplasia, there was no carcinoma in situ. The epithelium is absolutely
yes,
normal.
ma'am. Keratin pulse also I couldn't see keratin
Yeah,
pulse.
and the tumor is not arising from the epithelium, it's coming somewhere from the stroma. So yeah, it's not a squamous cell carcinoma, but I feel that from a practical standpoint, maybe it's better to exclude it. So as you said, so there was tumor. It had a very pushing margin, which is also another thing which is not in favor of an SEC, because you would expect to see infiltrative margins, lot of necrosis and mitosis if it was an SEC, none of which was here, and more of pushing margins as you can see in this slide. The tumor cells were arranged in sheets. It had a vaguely storiform pattern of
Yes,
architectural traces. It had a sprinkling of small lymphocytes, which are important. Pseudo-inclusions, like you mentioned.
yes,
Some
ma'am.
tumor cells were clustered like this with
Yes.
internuclear-free zones, right? Here also you can see clustered tumor cells. What
Yes, ma'am.
IFC would you like to know now? Or what would you want to see?
Ma'am, the key positive markers being CD21, 23, and CD35,
Okay.
the classic FTC markers.
Okay. So suppose you've got the facility to do only 4 markers. Which markers would you do? To confirm your
Ma'am, clustering for
okay.
CXCL13, ma'am.
Okay. What about to exclude your other deficiencies
Clustering
you had?
positive for epithelial markers, ma'am, like P40 and P63
Yes.
cytokeratins to exclude.
Okay. What about for interdigitating dendritic cell sarcoma, which is your other differential?
Uh, Ma'am, in IDCS, S100,
Yes.
CD64, and CD45 would be there.
CD60.
Vimentin also
Yeah.
positive.
Okay, fine. So these are the markers. So we
68,
did a
ma'am, sorry.
CK which was negative, S100 was negative, and the CD1A was also negative. CD1A for, although not really indicated, we just did it for completion, but still just out of curiosity, CD1A would be for Langerhans cell tumors, right? So this is CD23.
Yes, ma'am.
What do you think it shows? This is the tumor. These are the lymphoid
Yes,
follicles.
ma'am.
Positive or negative?
Ma'am, positive for B cells.
CD23 will be positive where? It's highlighting some cells in
It's
the
just on B
normal.
cells.
No, you quoted CD23 as a marker for FDC sarcoma, right? So what cells would
Yes, ma'am.
CD23 highlight? B cells or follicular dendritic cells?
Ma'am, B cells, ma'am.
Okay, no,
And
CD23 is a marker for
follicular.
follicular dendritic cells, which is the marker for B cells, which sounds very similar to CD23. You've just got a number wrong. You would
And
do
CD68.
CD20. CD20 would be a B cell marker, right? This is not CD20, this is CD23. This is the other marker that we did, which is CD21. Positive or negative?
Ma'am, positive.
Positive. In what cells? Follicular dendritic cells?
Yes, ma'am.
Yeah, so we have a tumor which is positive for 2 follicular dendritic cell markers, CD21 and CD23. This is evidence enough to call it a follicular dendritic cell sarcoma along with supportive morphology, right? So this is a
Yes, ma'am.
follicular dendritic cell sarcoma. It's a malignant neoplasm. They are rare. There are just a few take-home points that I would want everybody to remember. One interesting thing is that FDC is actually characterized as a mesenchymal neoplasm under the hematolymphoid tumor chapter of WHO because it originates from perivascular progenitor cells and not from the lymphoid cells or the histiocytes. So it's actually a mesenchymal tumor. Most of them are extranodal, so it's important to keep, because its presence as a spindle cell neoplasm, it's important to keep this differential in mind when you've got odd looking tumors presenting in the retroperitoneum, in the GIT, especially in the anterior mediastinum, where thymoma could be a differential here. So keep this tumor in mind, and it's always wise to put in a marker for follicular dendritic cells if you see a tumor with this morphology. Another curious association that this has is with hyaline vascular Castleman disease. Some patients with Castleman disease can progress to get a follicular dendritic cell sarcoma due to altered immune regulation, is what they say. Can you tell me what cells these are? This is from a normal lymph node. The cell that is marked in red, what could this be? What normal cell is this? And it kind of recapitulates itself in the tumor that you just saw as well. You can just take a wild guess because you just spoke on it.
A dendritic cell.
Yes, these are follicular dendritic cells. So in a normal lymph node in the germinal center, you see them as cells which stick together. They're called kissing cells because they just stick together. They've got pale chromatin and small nucleoli. So these are normal follicular dendritic cells. And in the tumor, if you saw, the cells had a tendency to cluster together. So I feel it's because the normal cells also tend to cluster together like this. Out of curiosity, do you know what is kissing disease? It's fine if you don't know.
Infectious.
Yeah, mononucleosis, right. That's kissing disease, and these are kissing cells. So according to the WHO, you should get at least two markers, two follicular dendritic cell markers positive in a tumor to call it a follicular dendritic cell sarcoma. So like you said, CD21 and 23, cluster in CXCL13. There are many other markers, but the first two markers are what we had, and that is what we did. Before I come back, the differential diagnosis for this, like you said, a very close differential is interdigitating dendritic cell sarcoma, which can look very similar to an FDC sarcoma. However, these tumors are positive for S100 because they are again histiocytic. The broad histiocytic comes under that. So S100 will be positive and it will be negative for follicular dendritic cell markers. There are other tumors in the WHO which arise from follicular dendritic cells, which are even rarer. One which could look a little bit like of FDC sarcoma is the EBV positive inflammatory FDC sarcoma. However, the background will be rich in lymphocytes and plasma cells, and they're usually common in the liver and the spleen and not in the lymph nodes, although you can get them in the lymph nodes as well. So these are the two main differential diagnostic considerations in this case. So the other interesting feature here is that you highlighted that there were a sprinkling of lymphocytes in the background, right? So these lymphocytes are usually B cells or importantly TDT positive T lymphoblasts. So we did do a TDT stain in this case, which highlighted scattered TDT positive cells. But the important thing to note here is that if you get lots of TDT positive cells, these patients are at increased risk of developing paraneoplastic autoimmune manifestations. So this was a paper which assessed these autoimmune manifestations in these tumors. The most common ones that they saw were skin and mucosal erosions, as well as lung lesions. Bronchiolitis obliterans is what they have seen in this study. And these patients end up doing poorly because they have a lot of morbidity secondary to the autoimmune disease and not due to the tumor per se. So it's always a good idea to assess TDT positivity in these tumors. Prognosis wise, they do well if there are no adverse prognostic features. Adverse prognostic features are increased size, mitosis, necrosis, atypia, your usual adverse prognostic features. If the patient does not have any of these, which this patient did not have, they do well. And complete resection is actually curative. So this patient, when I followed up, I mean, it's just been a few months, but she's had a complete tonsillectomy done, and they're just keeping her under follow-up with no adjuvant treatment. They can metastasize and they can recur locally as well. So that is the end of this case. Any doubts you can ask. Thank you.
Thank you, ma'am. Thank you, ma'am. Thanks.
We'll have the next spotter. This is a 18-year-old male with convulsions, and this is an autopsy of brain tissue. Can you identify which part of brain this could be? Is my screen seen now? Visible? Can you identify which part of brain is this? Good. Can you identify what cells are these? Okay. Okay. No, a 19-year-old boy with convulsion, Nigri bodies. And this is the IHC with the anti-rabies antibody, which shows positivity. These are intracytoplasmic eosinophilic inclusions, which can be seen in Purkinje cells of cerebellum. The viral replication happens in the cytoplasm, and that can be highlighted with these antibodies, anti-rabies antibodies. Thank you. Can we go on with the next presenter? Next presenter, please.
Hello, ma'am.
You're audible.
Okay. I'm audible, ma'am.
Dr. Rachna, you're audible, Dr. Rachna. Can you share your screen, please?
We shared it, ma'am. It's visible, ma'am. Screening.
No, your screen is not visible.
Request Dr. Shreya to stop sharing.
Sir, it's visible.
No, not yet. Rachna, I think stop sharing once and just come back live again. Yeah. Dr. Shreya, I think you have to wait for your turn. Please stop sharing your screen.
Sir, she's presenting from my screen, sir.
Dr. Rachana, is it?
Pradnya, sir.
No, no, Pradnya, your turn is D3, right? We're
D3,
discussing
sir.
D2. Dr. Rachana? All right, we will take up D3 now. Dr. Shreya, please share your screen and present the case. Dr. Shreya. Dr. Shreya, unmute, please. Dr. Shreya,
Yes, sir. Sir, is it visible?
put it on slideshow mode.
Sir, D3A, Pradnya is presenting.
It's okay, but you are presenting, right? The laptop.
In her
Sir,
laptop.
same laptop we are using, sir.
I agree. Please put it on slideshow mode.
Yes, sir.
Sir, is it visible, the
No,
slide?
no. I think you're sharing the window. Please share the entire screen. Stop sharing and click on entire screen. Dr. Shreya, click on share screen and select entire screen.
Sir, no.
Sir, now, sir?
No. Select entire screen. The option is there. When you click on share, you get three options. Chrome, window, and entire screen. Select entire screen and then share.
Please enter your screen. Okay, sir.
Now open your PowerPoint and yes, yes.
It's invisible, sir?
Let's go.
Myself, Pradnya Shetty, second year postgraduate from Adi Chinchingiri Medical College. And the case allotted is the case number D3, A1, A2, A3 we got, and the history is a 70-year-old male swelling in the left side of neck, FNAC positive for the malignancy. And in the scanner view, at low magnification, poorly circumscribed lesion with infiltrative borders noted. At whole mount view, variability in appearance from area to area. And pleomorphic, irregular nuclear membrane, prominent nucleoli. Open chromatin and prominent nucleoli can see. And in this slide, we can see the apoptotic cells. And in the next slide, we can see the solid sheet of atypical cells with the increased blood vessels. And in the next magnification, we can see the multinucleated gene cells. And in the next slide, we can see the rhabdoid cells. And in the next magnification, that is a D3A2 slide, we can see the few rhabdoid cells along with the increased blood vessels. And in the next slide, we can see the intracytoplasmic lumina containing RBC and pseudo-lipoblast are also seen. And in higher magnification, we can see the marsh cells and plasma cells. And here in this D3A3 slide, we can see the multinucleated gene cells and a lot of the blood vessels are seen. And in the summary, we conclude that section studied from the lesion shows a poorly circumscribed tumor with infiltrative borders. Cells are arranged in the solid sheet with many blood vessels. Individual tumor cells show pleomorphism, irregular nuclear membrane, coarse chromatin, and prominent nucleoli. Also noted are apoptotic cells and multinucleated gene cells.
Some area shows rhabdoid cells. Also noted are occasional pseudo-lipoblast in a background of inflammatory infiltrate comprising of lymphocytes, plasma cells, and mast cells. No areas of necrosis noted. So the differential diagnosis is the malignant soft tissue tumor, vascular origin, following possibility of can be considered. The two possibilities of differential diagnosis is the composite hemangioendothelioma and pseudomyogenic endothelioma. Thank you.
Thank you, Dr. Pratna. Can you please mute your mic? Okay. Thank you, Dr. Pratna. Am I audible?
Yes, you are. Go ahead, please.
Okay. So this was a 70-year-old male with neck swelling. It was a soft tissue swelling. So grossly, this is what we had received. A very well circumscribed mass, which was oriented with sutures. There was no deposits or it did not appear infiltrating on the surface. Cut section appeared to showed a homogeneous tumor with attached fat tissue. There were no heterogeneous areas like cystic areas or necrotic areas or hemorrhagic areas. Coming to microscopy, this is the low power view of the tumor, which appears to be very well circumscribed. This is the attached adipose tissue that does not show any infiltration in this view. And we see a very cellular tumor here. As we go to the higher power, we see that there are cells arranged in fascicular pattern as well as in sheets, and there are a lot of vessels. Further higher power, we see that these cells are pleomorphic cells, which demonstrate multinucleation, bizarre vesicular to coarse chromatin. Some of them have nucleolus, and most of the cells also have pseudo inclusions, as we can see here and here. So these are the pseudo inclusions, which is nothing but the cytoplasm that is entrapped. Lot of multinucleated, bizarre appearing cells. Along with these cells, we see there are a lot of mixed inflammatory infiltrate comprising of plasma cells, lymphocytes, neutrophils, and mast cells. And there are vessels around which these cells are seen. But one striking feature, it was a 5 centimeter mass and about 5 to 6 sections were taken. And the striking feature was that there was no necrosis and no mitotic figures detected in all of these sections. So what do you think it would be? Lymphoma or sarcoma? Dr. Pragna?
Yes, ma'am.
Sorry?
Sarcoma, ma'am.
Sarcoma. Okay. In sarcoma, what do you think it is? Low grade or high grade?
High grade.
Why do you think so?
Because of pleomorphic cells.
Okay, pleomorphic cells are the only criteria to call sarcoma as high grade.
And we can see the multinucleated dead cells and pseudo inclusion.
Yeah, did you find any necrotic areas or mitosis?
We did not see, ma'am.
Okay, so the tumor did not have any areas of necrosis or mitosis, and it was a very well circumscribed lesion. The DDs that you suggested will be a locally aggressive tumor. It will have varying areas.
Yes, ma'am.
It will have varying areas in the sense it will have it is said that in WHO, for composite hemangioendothelioma, it should have at least two distinct morphological patterns in the tumor. Like it should be a combination of angiosarcomatous areas with retiform hemangioendothelioma or epithelioid hemangioendothelioma. That is how it is described. And the other DD that you have given will not have this much amount of pleomorphic cells. And it will also be locally aggressive tumor. So what IHCs do you want to suggest from here?
CD31 and CD34.
Anything else? Okay. My experience. Okay. The differentials that was given were Hodgkin's lymphoma, anaplastic Hodgkin's-like lymphoma, epithelioid sarcoma, pleomorphic sarcoma, and composite hemangioendothelioma. Why is it not Hodgkin's lymphoma? First of all, because in Hodgkin's lymphoma, these pleomorphic cells or weak Sternberg cells are seen scattered in a very lymphoid background. It will have polymorphous lymphoid background within which you'll see scattered weak Sternberg cells. That was not the morphology seen here. And you will see normal parts, residual parts of lymph node as well, which is not appreciated in this case. Anaplastic Hodgkin's lymphoma will be associated with a lot of apoptotic bodies, mitosis, necrosis, and why it is not epithelioid sarcoma or pleomorphic sarcoma, again because there's no necrosis and there's no mitosis, and it is a well circumscribed tumor. Composite hemangioendothelioma, I already told it will have multiple morphological patterns along with it being a very highly infiltrative lesion.
Okay.
So we went ahead and did CD34 along with S100, Desmin, and KI67 as initial panel. So this was CD34, which showed diffuse membranous positivity. As you can see, these are the tumor cells, and this is the membranous positivity that you see. So what do you think it could be at this level? It shows diffuse CD34 positivity. Now that I've told you it is a low-grade tumor, it's a low-grade tumor with CD34 diffuse expression.
Opposite hemangioendothelioma.
Its CD31 was negative. So these are the other IHCs that we had done. As you can see, the internal control is positive. The tumor cells were negative. S100, the tumor cells showed negative expression. KI67 was less than 5%. Cytokeratin was done to look for focal cytokeratin positivity, which is seen in case of and this is ionized, which was retained, ruling out epithelioid sarcoma.
So what is your diagnosis?
What is your diagnosis now? Diffuse CD34 positivity with low Ki and INI retention. CD31 is also negative.
Epithelioid sarcoma.
INI is retained. And cytokeratin is negative. Okay. So the diagnosis that we gave was superficial CD34 positive fibroblastic tumor and pleomorphic lipoma. Both of them can show CD34 positivity. So superficial CD34 fibroblastic tumor is common in males, especially middle-aged males. It presents as a subcutaneous lesion involving not only the lower extremity. So coming to the microscopy, it's a very well circumscribed tumor which will have These fascicular arrangement of these large eosinophilic cells with glassy cytoplasm with marked nuclear pleomorphism, low mitotic count, and pseudo inclusions in a background of mixed inflammatory infiltrate. So on immunohistochemistry, we see that it will express CD34 diffuse positivity, focal keratin expression. With cytokeratin, there was also done to see if we could find any focal immunoreactivity with cytokeratin, although in this case it was not found. Another close differential is pleomorphic lipoma, which is again more common in male, presenting as a subcutaneous mass in the neck. It is also well circumscribed. It will be encapsulated. But pleomorphic lipoma is a type of spindle cell lipoma. So it will have bland spindle cells along with these multinucleated florets-like cells in a background of myxoid matrix and ropey collagen that also expresses CD34. So to differentiate between these two, what we can do further is to look for expression of RB gene 1. So superficial CD34 positive hypoblastic tumor is a new entity with low-grade neoplastic skin and subcases. Few cases are only reported. Prognosis is said to be excellent with complete excision. We went ahead and did a RB gene. We could see the majority of cells were negative for RB gene. These are the tumor cells that are not expressing, nuclear expression is not seen in. So that favors pleomorphic lipoma, but morphologically, we couldn't see much of floret cells or bland spindle cells or megastocytes and ropey collagen bundles in a fibromyxoid stroma, which is essential criteria for calling it as pleomorphic lipoma. RB gene expression is desirable criteria. Prognosis in pleomorphic lipoma is also very good with complete resection. Thank you.
Thank you.
We'll go ahead with the spotter. 78-year-old circumferential ulcer in perineal region with bleeding, acute on chronic kidney disease. What are these cells? Can you see the slide? What are these cells? What are these structures? Is it visible?
Yes, it is. Yes, it is.
Okay.
Any other PG can also unmute and share the response.
So it's there is condyloma here, is ulceration. In high power, we saw these cells. Can someone tell me what are these cells?
We're getting some responses in the chat box.
What is this cell?
What are these cells? Okay, these are the trophozoites within which you can see engulfed RBCs. So this is a case of cutaneous amoebiasis. Okay, thank you.
Dr. Rajeshri got it right.
Thank you.
Anita, ma'am, which case are we taking up next?
Aditya?
Which case are we taking up next, ma'am?
We'll complete the D3B.
D3B. Dr. Shreya, could you please share your screen?
Yes, sir. Yes, sir. Sir, my presentation is visible.
Go ahead.
Good afternoon. I'm Dr. Shreya Johari, second year postgraduate from Aditya Institute of Medical Science. I was allotted the case of D3B slides. There are two virtual slides. The history is 42 years old female, right thigh, intramuscular swelling. This is a whole mount showing poorly circumscribed tumor. This is tumor is composed of tumor cells, spindle tumor cells arranged in hypo and hypercellular area biphasic pattern. This is the area. Then we can, in the high power magnification, we can see the numerous thin-walled blood vessels which are in staghorn in shape. Then we can also see the hyalinized thickened blood vessels and the bundles of skeletal muscles and entrapped adipocytes. Cystic areas, degenerative and hemorrhage is seen. Focal areas of lymphoid aggregates and adipocytes are seen. Also seen fibrillary eosinophilic material with the plump spindle cells. These spindle cells are spindle to stellate in shape with delicate cytoplasm, bland chromatin and small prominent nucleoli. Some atypical large cells are also seen. Coagulative necrosis we can see and along with numerous fine blood vessels. Atypical loose myxoid stroma is seen with the collagen. Slight pleomorphisms from spindle to oval cells are seen. This lesion shows poorly circumscribed tumor with biphagic pattern of hyper and hypercellular areas composed of the spindle to stellate and oval cells arranged in diffuse wake pattern. Individual tumor cells are plump with delicate cytoplasm, bland chromatin, and small prominent nucleoli. Tumor cells show slight pleomorphism with necrosis extending into the adjacent soft tissue with entrapped adipocyte tissue at the periphery. Abundant hyalinized thickened wall blood vessels are seen with cystic areas of degeneration and loose fibromyxoid, bland collagenous stroma, showing atypia, mild to moderate chronic inflammatory cells infiltrating, comprising of lymphocytes and plasma cells, admixed with fat cells, is present at the periphery with focal myxoid change and hemorrhaging background. My differential diagnosis more towards angiomyxoma and one more DD low-grade fibromyxoid sarcoma. Thank you.
History. Can you mute?
Yes,
42-year-old with right thigh intramuscular swelling. So this was the gross specimen that we received. Here you can see a fairly circumscribed tumor measuring around 8 into 5 into 4 centimeters. There is on cut surface, the tumor appears tan brown. Uh, uh, ex- there are adipose tissue areas seen on the external surface. So microscopy, where what we can see is a fairly circumscribed tumor. There are hyper and hypocellular areas which we can see. There are some cystic spaces in the periphery. Below the capsule, what we can see are some lymphoid aggregates. On higher magnification, we can see that there are spindle-shaped cells which are arranged haphazardly. There is no particular pattern of arrangement. Admixed with them are these blood vessels, thin-walled blood vessels. On higher magnification, these spindle cells have a bland nuclear morphology, scant cytoplasm. There is no mitosis or there is no necrosis anywhere in the slide. So summarizing the microscopic findings,
There is a fibrous pseudocapsule. There is some focal peripheral cuff of lymphocytes. Randomly arranged, bland appearing spindle shaped cells are seen. Some vascular spaces are there. The stroma, mostly it is edematous to some fibrocollagenous stroma is there. There is scattered chronic inflammatory cells and there is no atypia or mitosis. So our differentials were a neural tumor or a solitary fibrous tumor. The multiple differentials we received were, the majority of them suggested a low-grade myxofibrosarcoma. Others were aggressive angiomyxoma, hemangioendothelioma, schwannoma, solitary fibrous tumor, or low-grade fibrosarcoma. So moving forward with IHC, what are the IHC markers you would suggest to do?
Ma'am, CD34 and HMG-A2, ma'am.
Okay, for your diagnosis of?
Ma'am, angiomyxoma aggressive.
Okay, and any other markers? To rule out anything else, what was your other differential?
Ma'am, low-grade fibromyxoid sarcoma, ma'am. MUC4, ma'am, should be negative.
MUC4 should be?
Negative to rule out fibromyxoid sarcoma, low-grade.
Fibromyxoid sarcoma, MUC4 should be positive. Okay, so for the IHC markers which we did, first I will show the positive marker. This is IHC for Desmin. Can you identify what is the pattern of staining in this?
Yes, ma'am. Reticular.
Yeah, you're almost there. It is cytoplasmic staining with dendritic pattern, which is characteristic Desmin positivity. So will your differentials have a Desmin positive staining? Either an angiomyxoma or a myxoid fibrosarcoma? Angiomyxoma can show Desmin positivity. Okay. The other markers which we did were SMA, Soxton, CD34, beta-catenin and S100, all of which were negative. So this kind of rules out an angiomyxoma or myxoid fibrosarcoma. Otherwise, coming to morphology also, with these differentials, aggressive angiomyxoma, there were no vascular spaces to signify that. So conclusively, our diagnosis was an angiomatoid fibrous histiocytoma. So differentiating it from the majority differential, that was low-grade myxofibrosarcoma. In both, there are bland appearing spindle cells, but in angiomatoid fibrous histoma, they are arranged haphazardly. But in myxofibrosarcoma, they are arranged in short fascicles or in whirling pattern. The stroma here is edematous to fibrocollagenous. In myxofibrosarcoma, the stroma is collagenous stroma with abrupt transition to myxoid areas. There are no collagen rosettes in our case, and in myxofibrosarcoma, collagen rosettes are characteristic finding. In our case, there are other characteristic findings, including pericapsular lymphocytic cuff, interspersed chronic inflammatory cells, and scattered hemocytin deposition. And IHC, and in myxofibrosarcoma, Desmin will be negative. And to confirm, there is an EWSR1 rearrangement in angiomatoid fibrous histiocytoma. In low-grade myxofibrosarcoma, the characteristic gene fusion is FUS and CREB3L2, which is seen in more than 90% of the cases. So to confirm our diagnosis, we found a fish for EWSR1 rearrangement, which was positive.
Yes, ma'am.
So our diagnosis was of angiomatoid fibrous histiocytoma. This is basically a diagnosis of occlusion with IHC and correlating with morphology, with finally positive EWSR1 rearrangement. Now, next coming to the spotter. Okay, angiomatoid fibrosystoma, it is a rare tumor. It comes under the WHO category of tumors of uncertain differentiation. It is of intermediate malignant potential and accounts for about 0.3% of all the soft tissue tumors. It occurs as subcutaneous lesions and most commonly in the extremities. Most tumors follow an indolent course with local recurrence in nearly 15% of cases and metastasis in less than 2 to 5% of cases. It metastasizes predominantly to locally to lymph nodes and rarely to lungs, liver, and the brain. So the references. So coming to the spotter, this is biopsy from a 66-year-old male aortic valve. And for this, according to the diagnosis, is homogenesic acid was detected in the urine of this patient. So, can somebody tell me what is the deposit which we are seeing?
Alkaptonuria.
What are they called? What is the deposit and what is the disease? You were correct. Shreya, you were correct. Can you repeat it?
Yes, ma'am. Alkaptonuria, ma'am.
Okay, what is the deposit? What is the disease called?
Homocysteine, ma'am.
Homocysteine is the deposit. The
Yes,
word
ma'am. On granules.
what the special stain ochronosis, that's correct. The special stain which we have used here is methylene blue, which shows blackish discoloration of the
Yes.
deposit.
Deposits, yes, ma'am.
Is the deposition disorder characterized by homogenesic acid in connective tissue, characterized by blue-gray to black pigmentation due to deposition of ochre-colored pigment in connective tissues. It's of two main forms, alkaptonuria or endocrinosis, because of the deficiency of enzyme homogentisate 1,2-dioxygenase, and exogenous uchronosis because of overuse of topical hydroquinone or other medicaments.
Thank you, ma'am.
I think we can now ask Dr. Rachana if you can try once to share your screen and unmute yourself.
Yes,
Rachana,
sir.
be
Yes.
audible.
I'll share my screen, sir.
Go ahead.
Is my screen visible, sir?
Yes, so minimize and open your PowerPoint.
Now it is visible, sir?
No. Stop sharing and try sharing your entire screen. If you have anybody
Yes.
there to help you with the technicals, I think
Yes,
can
sir.
ask for help
Yes.
as well. Just click on share and select entire screen.
Now it is visible, sir?
Yes, do that. Go ahead.
Yes. So my case number is D2, case A, 65-year-old male, nasopharyngeal mass obstructing and extending to sphenoid sinus, extending to the cranial cavity and eroding to bone. One slide enclosed. This is the scanner view. We can see the respiratory epithelium. Here, section study shows normal-looking respiratory epithelium, that is pseudostratified ciliated columnar epithelium. In this section, we can see the cells are arranged in cords and sheets. In this slide, we can see the small blue round cell with eosinophilic to clear bubbly cytoplasm compressing the nucleus and creating the characteristic physalliferous cells arranged in cords and sheets. These cells are embedded in a myxoid stroma and areas of fibrosis are seen. So for my first case, differential diagnosis is chordoma because of physalliferous cells and chordosarcoma low grade. My final diagnosis is chordoma and suggested IHCR cytokeratin EMA S100 and brachyury. Case number D2B, 30-year-old female with left knee query MCL ganglion cyst, query post-traumatic collection. Two slides are enclosed. In this section, we can see the muscle fibers and fibroadipose tissue with well circumscribed region. The lesion, in this, we can see the lobular arrangement of the cells and separated by the fibrous septae. Here, we can see the cystic change. In this, we can see the lobular arrangement of the cells, and these are separated by the fibrous septae. In this section, we can see the hypercellular and the hypocellular areas. In this section, we can see the cells are round to spindle, stellate cells with eosinophilic cytoplasm embedded in myxoid matrix. In this, we can see the hypercellular area with liquefactive matrix. Here we can see the cystic change. In this slide, we can see the areas of hemorrhage. So my differential diagnosis for this case is low-grade chondrosarcoma, chondroblastoma, chondroma, and chondromyxoid fibroma. And my final diagnosis is chondromyxoid fibroma. Suggested IHCs S100, SOX9, and SMM. Thank you.
Okay, thank you, Dr. Rachna, for presentation. This case is very interesting. Actually, D2A and D2B case is slight overlapping, with only one or two morphological features are there to differentiate between these two entities. This case is 65-year-old male presented with nasopharyngeal mass that is extending to sphenoid sinus and base of skull with bone erosion. This slide came for second opinion, and outside it reported is the adenocarcinoma of nasopharynx. Okay, as you described, the tumor is composed of two component. One is the very large epithelioid cells, which is not that much pleomorphic, but the heterogeneously somewhere it low grade, somewhere it's showing high grade, and abundant eosinophilic cytoplasm that arranged in course, then small nest, and individually, right? And the other component is that vacuolated bubbly cytoplasm. That's what you called physelliforous cells. Now, can you tell me why there is a clear cytoplasm here? Dr. Rachna?
Yes, yes, ma'am.
Yes, can you tell me?
These are the physelliferous cells having bubbly cytoplasm.
Yes, but this
Clear
clear
vacuolated
cytoplasm is because
cytoplasm.
of what? It's because of the glycogen. Okay, that's why
Glycogen, yes.
it's clear cytoplasm. And
Yes.
yes, all are bubbly physelliforous cells. And what is the differential diagnosis at this stage in the nasopharynx? Because I
Uh,
don't think it's
lo-
very common site for this tumor.
yes. My differential diagnosis is low-grade chondrosarcoma.
Okay. Okay, other than that,
Nasopharyngeal carcinoma.
okay. I think all the cells in that you can see the myxoid matrix. Okay.
Myxoid matrix.
So the low grade chondrosarcoma will be closed DD, and the other DD will be a extraskeletal myxoid chondrosarcoma. The same morphological features you can see, but the only differentiating point is these physelliforous cells, and these cells are more about epithelioid. While in AMC you can see the long cytoplasmic processes and the lobular architecture. Okay, here we can't see that morphological features. Now, what will I see you prefer to differentiating all these entities?
Ma'am, IHC brachyury, it is the most specific marker for chordoma. It shows
Why
nuclear
it is specific
positivity.
for chordoma? Why it is specific for chordoma?
Um,
Okay, what other markers you will do?
Other markers, ma'am, cytokeratin.
Okay,
For epithelial differentiation, ma'am, CK AE1,
okay,
AE3, CK19, CK8, 18, and
okay,
S100, ma'am. It
okay,
shows strong and diffuse positivity, and EMA, ma'am, epithelial membrane antigen. It shows focal and diffuse positivity.
okay. What are the markers? You have to differentiate it from extracellular myxoid chondrosarcoma also. So for that, what will
Uh,
other markers you do?
For that, ma'am, SOX9 that is negative. It helps to distinguish from the chondrosarcoma. And IDH1, it's also negative. It exclude chondrosarcoma.
Okay, for chondrosarcoma, there is only one marker that is 100. And okay, tell me morphologically, how can you differentiate this from chondrosarcoma? Besides this phyceliferous cell.
One thing is phyceliferescence and uh, uh, both are having lobulated pattern. Here in chordoma, ma'am, myxoid and gelatinous background, and in chondrosarcoma, hyaline cartilage matrix will be there, ma'am.
Okay. Okay, see, in this chondrosarcoma, there will be a cartilaginous,
Chondrocyte.
huge cartilaginous
Yes.
matrix. In this, there is a chondrocytes which are atypical and that seated in that lacunar space. And they
Yes,
are
ma'am.
this binucleated, multinucleated. This, you can see this kind of,
Yes.
this you can see. This we are not seeing in this case.
Yes, ma'am.
And in
Chondrocytes are
little myxoid chondrosarcoma, there is a lobular architecture that is also present in chordoma. But the thing is, the cells are very spindle. There is no spindling of the cells are noted. Here, the spindle cells with long cytoplasmic processes are there, right? So, and there is some hemorrhage,
yes,
hemorrhage affects these lobules, areas of hemorrhage. And the further discussion that Dr. Shilpa will tell about this differential diagnosis of EMC also. Okay, so positive stain is pan, CK, and brachyury. And what we did, that marker is 100, SMA, CD117, and synaptophysin all were the negative. That rules out the possibility of the low-grade chondrosarcoma and EMC. So this is the pan-CK positivity. Thus, all cells are diffuse membranous positive. And this is the brachyury. Which is, all the cells has a strong nuclear positivity. So now why this tumor specific for brachyury? So basically this tumor is arise from which cell?
Uh, it arises from the clival body, ma'am. Clival.
No, that is the
It is
site.
a notochordal
Okay, yeah,
lineage,
it
ma'am.
is not.
Embryonic
So there is
origin.
one gene that is a TBXT
T gene.
which
Yes,
encode this brachyury, and that is the transcription factor which is required for notochord differentiation. That's why it's specific for this brachyury. Okay, as we have mentioned, tumor has a tumor with heterogeneously pleomorphic. Somewhere you can see low grade nuclei, somewhere you can see the high grade epithelial cells with clear to eosinophilic cytoplasm arranged in short cords, nets, and individually. These phyceliferous cells are there. Some nuclear pseudo inclusions also were there. Mitotically, it's low, 3 to 4. We can see on 10 high power field. There is no necrosis. There is no spindle cells. So the diagnosis is conventional chordoma. Okay, so can you tell me what are the different other morphological subtypes of the chordoma? This is the case of which chordoma?
this is a clival chordoma, ma'am. There are conventional chordoma, that is classic chordoma, ma'am. Then chondroid chordoma is there. Uh, uh, and ma'am, dedifferentiated chondroma, that is poorly differentiated. And rare varieties, myxoid chordoma.
No, actually there is only three entity. One is conventional slash chondroid chordoma. Second one is poorly differentiated, and third one is de-differentiated. In poorly differentiated, you can see the classical chordoma and this sarcoma-like area. No, in de-differentiated, you can see that biphasic appearance. In poorly differentiated, you will see the sheets of epithelial cells with rhabdoid morphology, and this tumor has SMARC-B1 loss. Okay. So the prognosis wise, it's intermediate to worse prognosis. Why? Because it's mainly depend on site and extent of tumor. Okay, how much tumor is operable? It's extent of completeness of resection.
And in this case, it's very difficult to excise completely. So may this patient have a worse prognosis. And also in a poorly and dedifferentiated subtype of the chordoma is worse prognosis. And some of the cases has metastasized to the lung, bone, lymph node, and subcutaneous tissue. And in WHO, this tumor has described in chapter of mesenchymal tumor of nasopharyngeal, sinonasal tract. Thank you.
Thank you.
This is a one spotter. 56-year-old male, right lower lobe mass with consolidation. Identify this area. What is this?
These are the actinomycosis.
Yes. Yes, this is the colony of actinomycosis. So this is the case of the pulmonary actinomycosis, which is done by caused by that organism, which is gram-positive slender filamentous bacteria, and also the GMS positive. And one of the close DD is nocardiosis. How can we differentiate this from nocardiosis? So there is one modified acid fast strain in that we use the 1% of sulfuric acid. That is the negative for this actinomycosis and that positive in nocardiosis. So that is the main differentiating point between these two. Okay, thank you.
Thank you.
Hello, Dr. Rachna.
Hello.
I'm your, yeah, hi. I'll be discussing case D2B. So your approach was good. However, this case is a little tricky considering the site, and without radiological findings, it's a little difficult. So let's see why. So we had a 30-year-old female who presented with a painful knee swelling, who gives a history of trauma. The operating surgeon describes it as a multiple lobulated cyst. The biopsy specimen was sent to us with a differential of medial collateral ligament ganglion cyst versus post-traumatic collection. So grossly, we received multiple glistening, whitish, soft tissue fragments, the largest measuring about 5 by 5 centimeter. And these tissue fragments showed few cystic spaces. Few of the spaces were filled with mucoid material. However, there were no bony tissue fragments noted. So light microscopy showed a lesion in the soft tissue, which was composed of multiple bluish nodules separated by fibrocollagenous set of variable thickness, altogether giving it a multilobulated appearance. So now these lobules were composed of tumor cells which were seen distributed on an abundant chondromyxoid matrix. Do you agree?
Yes. Yes, ma'am.
So if we look at the individual tumor cells, these tumor cells had a characteristic arrangement. If you look here, they are individual tumor cells are seen interconnected with each one another, forming a short chain or a linear cord. Apart from these linear cords, there were trabeculae, there were few clusters, tubules, and vague cribriform pattern. Individual tumor cells were uniform, bland, like you described. They were round to spindled with dispersed chromatin, eosinophilic to few cells showing vacuolated cytoplasm. If you carefully look at here, the spindle cells shows cytoplasmic extensions. This image highlights the vacuolated tumor cells and also the other cells which are bland, round to spindled. So what is most important in this case was these tumor cells showed no evidence of pleomorphism, neither was increased mitosis noted. So, and one point which I would like to highlight is we did not see any area of well-formed cartilage.
So, with our clinical and morphological findings and the imaging findings awaited, we had a differential of extraskeletal myxoid chondrosarcoma versus myoepithelioma. So, once the imaging findings were made available, we saw a soft tissue lesion involving the medial and posterior aspect of the knee, as seen in the X-ray. Further, PET-CT confirmed the soft tissue location of the tumor, further assuring us with the differential which we had going in favor of extraskeletal myxoid chondrosarcoma. So the underlying bones were absolutely normal with no involvement. Considering this diagnosis of ours, we went ahead with IHC. So initially we chose three markers, non-specific enolase, INS M1 and S100, all three of which shows positivity. Non-specific enolase and INS M1 showed diffuse positivity and diffuse strong positivity, whereas S100 showed patchy nuclear to cytoplasmic positivity. So with this IHC findings and the clinical and radiological imaging findings, our diagnosis of extraskeletal myxoid chondrosarcoma was confirmed. However, we still had a differential of myoepithelioma, so we just added another IHC marker, which was CK, and that turned out to be negative. So if we look at the image here on the right hand side, the HNE slide, so the morphology of these cells are almost similar to what we actually saw in the case. So with these findings, we signed out our report as extraskeletal myxoid chondrosarcoma. So with an advice to confirm for further confirmation by molecular studies. This entity is majority of the cases is associated with EWS NR4A3 rearrangement. Very few cases shows non-EWS variant, which shows local recurrence with metastatic potential. So if we coming to the differentials, majority had diagnosed this case as chondromyxoid fibroma. So what is characteristic about chondromyxoid fibroma is the zonation pattern. So you did describe the hypocellular and hypercellular areas, but Dr. Rachna, what was not seen is the zonation pattern. So we are appreciating the nodules which are separated by fibrocollagenous septa, but here the zonation pattern, I mean to tell, is the central hypocellular cells surrounded by the hypercellular periphery. So which is giving it a pseudo-lobulation appearance. So that is why this was not considered. And of course, this is without the imaging findings, because we all know chondromyxoid fibroma is a metaphyseal tumor. So the other differentials which we received were a set of cartilaginous tumors, which included chondroma, chondrosarcoma, chondroblastoma. Chondroma, again, we get to see nodules of well-formed cartilage, which were not appreciated in our case. So we rule out this one. Chondrosarcoma, in order to diagnose chondrosarcoma, we really need to have an infiltrating pattern into the adjacent bone. So even if you are seeing atypical chondrocytes, that could be chondroma, so the infiltrating pattern. So we are again not seeing this one. So we are ruling out chondrosarcoma. Whereas chondroblastoma, we are seeing sheets of cells with, like you can appreciate, chicken wire calcification. And if we look carefully, the nuclear grooving can be appreciated. So this rules out chondroblastoma. So few soft tissue tumors were included in the differentials, which included myxofibrosarcoma and low-grade fibromyxoid sarcoma. For diagnosing myxofibrosarcoma, we at least need some scattered atypical cells. So we did not see any atypical cells in our lesion. So this is ruled out. And again, myxofibrosarcoma shows other characteristic feature, which are elongated branching blood vessels. And coming to the low-grade fibromyxoid sarcoma, it is a pink tumor predominantly composed of hyalinized stroma with scanty myxoid areas. So that is why we are again ruling out this entity. So We did receive other differentials including ganglion cyst, synovial cyst, and chondromatosis. I'm not discussing about all of those. So to brief it up, take-home messages: extraskeletal myxoid chondrosarcoma is a malignant neoplasm which is accounting to less than 1% of soft tissue sarcomas. The most common site including the proximal and the distal soft tissue, and it is a slow growing tumor. Mostly the patients present to the clinician with a localized tumor, and the treatment is margin clearance plus or minus radiotherapy. And like I said, the non-EWS1 mutant shows local recurrence with distant metastasis most commonly to the lung. So the adverse prognostic factor for this particular entity being older age presentation, the larger size of the tumor, and the tumor in the proximal extremity. So because of its recurrence and the potential for distant metastasis, these patients are recommended to come for a long term, are followed up for a really long term. So shall we go ahead with the spotter? So there's a next spotter. 48-year-old female. Multiple biopsies were taken from ileum, colon, and rectum. So the rectal biopsy shows intracytoplasmic inclusions. So can you please tell us what these are? Hello, am I audible?
Yes, you.
Yeah. Okay. So since we are running out of time, so I'll be going ahead with the answer. So these are nothing but the von Hansmann cells, which are the round histiocytes with basophilic cytoplasmic inclusions, which are called as the Michaelis-Guttman bodies. The most common bacteria which causes this being the E. coli, and this is because of the defective fat. And I think some Proteus what is that? Okay, I forgot the other one. So it's basically because of the defective phagolysosomal activity. Thank you.
Thank you. With that, we will move to the two HAMAT cases. For that, I will first invite Dr. Krishna Priya from BMCRI to present S6.
Hello, sir. Is my screen visible?
Yes, go on.
Good afternoon, everyone. I am Dr. Krishnapriya S. Raja. I am third year postgraduate from Bangalore Medical College and Research Institute. I will be presenting spotter number 6. So the history that was given was 41-year-old male with splenomegaly. And from the this was the CBC data given. Here hemoglobin was 12.9 gram per deciliter. Indices were within normal limit. WBCs are increased 44,320. And from the DC, you can see that the neutrophil peak is increased like 75%. And there is prominent basophilia. Basophils are at 11%. And if you look at the platelets are increased. It is thrombocytosis. So from the CBC data, there is leukocytosis with the differential showing neutrophilic peak and prominent basophilia, and there is thrombocytosis. So this was the first image given. Here, the RBCs, they are predominantly normocytic, normochromic, and there are few microcytic hypochromic cells. We can also see poikilocytes like microspirocytes. Then we can see few pencil-shaped cells and few teardrop cells we can also see. Good number of polychromatophils can also be seen. And as you can see here, there was one NRBC was noted per 100 WBCs. This was the DC which was given. Among the 100 WBCs, as you can see, there's majority are neutrophils, and if you see these few band forms are also seen. And if you look at these neutrophils, they are showing abnormal segmentation. There is nuclear hyposegmentation, and there is cytoplasmic hypogranularity is also noted. So we can conclude that some degree of dysplasia is present in the neutrophil lineage. Now, this was the second DC, second pick of the DC. Here, as you can see, there is obvious basophilia. The basophils were at 11%, and the eosinophils were within normal 2%. And you can see the monocyte population. The monocyte population, it is increased. So, as you can see, these are large cells with abundant slate blue-gray cytoplasm, and some of them are showing cytoplasmic vacuolation, nuclear indentation. Some are showing convoluted nucleus also, and there is also I have found some circulating blast, but I have placed it 5% with some 2 or 3 nucleoli. So coming at the DC, the neutrophils I counted were at 38%, with monocytes at 29%, and eosinophils normal, and there is basophilia, and band forms were at 15%. And circulating blast was 5%, and 1 NRBC was noted per 100 WBC. So the peripheral smear description, RBCs were predominantly normocytic, normochromic with few microcytic hypochromic cells. Moderate degree of anisopoikilocytosis was seen in the form of microspherocytes, pencil-shaped cells, and few teardrop cells. Then again, good number of polychromatophils were seen, and 1 NRBC per 100 WBC was seen. The WBCs were increased in number, and there was basophilia was noted, there was monocytosis was noted, and shift to left was noted only up to the band forms. And these neutrophils, they were showing hyposegmentation, hypogranular cytoplasm, and abnormal segmentation. Circulating blasts were at 5%, and there was thrombocytosis. The platelet count was increased, and no hemophagocytes were seen. So from this DC and the images given, I concluded that since there is obvious some dysplasia in the neutrophilic lineage, and there is no classical peak at promyelocyte, myelocyte, metamyelocyte, but there is only like obvious basophilia, which is indicating towards a myeloid proliferative neoplasm. So I have concluded that the best I have come up with is hematological features may suggest chronic myelomonocytic leukemia, and the next good contender is chronic myeloid leukemia in chronic phase. So, as according to the WHO, there was peripheral blood monocytosis, and the blast cells were less than 20% here, and there was dysplasia involving more than 1 myeloid lineages, and there was WBC count was increased, and there is monocytosis was noted, and there was dysplastic features in the neutrophil, and myeloproliferative features were also noted. So this was the morphological diagnosis this was given. So leukemoid reaction with infectious etiology, the neutrophil didn't show any toxic changes like vacuolation, cytoplasmic granules. So I have ruled it out. Acute myeloid leukemia, then again the blast population is less. Lymphoproliferative disorder, the DC didn't suggest so. So I have come with the other option with chronic myelomonocytic leukemia as my first DD, and second as a best contender is chronic myeloid leukemia in chronic phase. And the next question that was asked was, what are the follow-up investigations? The first statement, bone marrow is mandatory. I wouldn't say that it is mandatory, but then again the classic features of increased ME ratio, then myelomonocytic differentiation, hypercellular marrow could be appreciated, but bone marrow is mandatory. I wouldn't go with that. CRP levels will be increased in a leukemoid reaction, but here I want to, since my first differential is CML and CP, I would like to go with the molecular studies for BCR-ABL gene fusion status and look at the BCR-ABL gene status, because there is one P190 BCR-ABL gene isoform in CML, which is actually a rare mimicker of CMML with monocytosis. So I would go with quantitative PCR molecular studies for BCR-ABL. Then I would like to go with cytogenetic studies for BCR-ABL gene fusion status, like for reciprocal translocation 922 to identify it on fish, and also karyotyping. Then since it is associated with a lot of mutations, and like in 1 to 2% of CMML patients might have a AML NPN1 mutations. So like that, and because of prognostic significance, I would also like to do next generation sequencing for myeloneoplasm associated gene mutations. And in order to categorize the monocyte fraction in CMML, like the classical monocyte fraction, which is CD14 positive and CD16 negative, which is that fraction is increased in CMML. So I would also like to go for flow cytometry for immunophenotyping. Thank you.
Yeah. Am I audible?
Yes, sir.
Yeah. Okay. Thanks for a kind of elaborate presentation, but okay, just before that, when I actually got the list of cases assigned to the colleges, I think have best of my friends in KIMS and BMC, so that was actually good. But then now coming to the case, the first thing is uh, about CMML being the diagnosis. Before getting on to the WHO criteria, the first thing is the median age of CMML. It's kind of definitely a disease of elderly. We would not expect that to come in a 41-year-old, which is extremely rare. So we would still give CML to be the possibility, but let's go step by step. So this was a history given 41-year-old with splenomegaly, and this was the CBC data. The WBC being at 44,000, very like near normal hemoglobin, but platelet being increased. And then when we looked at RBCs, I think this, since it's a static image and we have taken few areas, these are kind of slightly artifactual. We'll not discuss much about that because the hemoglobin is near normal, so we'll not go to that. But as we can see, we have a lot of these cells which are eosinophils, and there are some basophils, and then you have the mature neutrophils, and this was a thing which was given. Now when we look at these kind of neutrophils, as said, this may be confused with what a MDS neutrophil can look like, but these are definitely these kind of neutrophils. If you can go back and see in any of your CML diagnosed cases, you'll have a lot of abnormal segmentation, which is a part of a myeloproliferative neoplasm itself and need not have an additional MDS component. And then coming to the other cells, you have few monocytes, yes, but these are your left shifted cells. These are myelocytes basically, and you have a lot of basophils which have come up, and again there are few blasts. So all in all, we are looking at a high WBC count with basophils and eosinophils. The only thing that has to strike first is a myeloproliferative neoplasm. And also, in addition, if you can just look at the platelets in all these, or if we can say here, this is a platelet which is very lightly stained but large, and then you have a small platelet again which is darkly stained. So you have this platelet anisocytosis. So in addition to anisocytosis, you have the intensity in which they are staining, that is different. So these two are more towards a myeloproliferative neoplasm in any given day. So your leukemia reaction gets ruled out and rest of it. But this thing, what the answer was expected was it is a myeloproliferative neoplasm and it's likely to be CML in chronic phase. And Dr. Krishnapriya also told that since the blasts are less, I would not consider AML, but that's not right because now you have a category of AML with known cytogenetic abnormalities where the 20% blast is not a criteria. So that may be a wrong perception. And then the other question which we asked was, is bone marrow mandatory in these? Absolutely no. If you have enough evidence on the peripheral blood and there is no borderline increase in the blasts or the basophils, you can straight away get to a molecular studies for BCR-ABL, so or even cytogenetic studies for BCR-ABL. A molecular study like a PCR it would be much better because we have to know what is the transcript type. It is 210, 190, because that is your MRD. Whenever you think of a patient with CML, your MRD is your PCR based analysis. So at diagnosis, you know what transcript it is, and based on that, we start monitoring the patients, and that's how you would know the treatment response. So this question, the only options which we were looking for was molecular studies or the cytogenetic studies, but molecular would be much better. But given the fact that since there were not much of left shift, even if you're giving a NGS for other MPN associated mutations, we would take it. So the final diagnosis of this case was it's a myeloproliferative neoplasm and it is CML in chronic phase. And this person had major transcript, and uh, this person was started on nilotinib rather than how we used to start patients with imatinib previously. So just go through how CML treatment has changed right now, because before we were looking at a disease-free survival, but now we look at overall survival or things like that. Okay. Can we have the next case?
The next and the last case by Dr. Leah from KIMS, Bangalore.
Any doubts with the previous case? Nothing.
Sir, is my screen visible?
Yes.
Put it on slide share mode and go ahead.
Good afternoon, myself Dr. Leah Varghese, third year postgraduate, KIMS, Bangalore. I have been allotted case D4. First case is 32-year-old female, complete blood count in the first run showed platelet count of 23 lakhs, WBC being 10,700, hemoglobin 7.2 gram per deciliter, and a flagging was noted of basophilia and NRBCs, relative count being 2.6%. CBC in the second run showed platelet count of 33,000, which was below normal, and all the other parameters remained the same. Coming to normal, here the R skewed to the left with increase in RDW showing heterogeneous population of RBCs and extended descending slope. In the platelet histogram, we can see that the PDW, platelet distribution width, is increased and the upper discriminator is not touching the baseline with ragged appearance of the descending slope. So both the histograms appear abnormal. The neutrophils shows dysgranulopoietic changes of hypogranulation and hypolobated neutrophils. Basophilia, 3 basophils were noted, and under lymphocytes, reactive or atypical cells were seen, most majority of which were monocytoid forms, and 13 NRBCs seen. Coming to the peripheral smear, RBCs shows mild to moderate degree of anisopoikilocytosis. Seen are microcytes admixed with normocytes. Also seen are many microspherocytes, elliptocytes, teardrop cells, few fragmented RBCs, and $23 lakhs, WBC being 10,000, hemoglobin 7 gram per deciliter. And in the second run, platelet count came down to 2,67,000, which was in the normal range, and all the other parameters remained the same. Coming to the RBC and platelet histogram, Can see the RBC histogram is skewed to the left with lower discriminator not touching the baseline, and RDW is increased here, showing the heterogeneous population. In the platelet histogram, platelet distribution width is increased with upper discriminator not touching the baseline. From the peripheral smear, RBCs show moderate to severe with normocytes. Also seen are elliptocytes, teardrop cells, many fragmented RBCs, many polychromatophilic cells also noted. And the WBC and platelets remain the normal. Maybe the platelet discrepancy that is abnormally high value in the first run, maybe because of the fragmented RBCs being counted as the platelet. The impression can be hemolytic anemia, and in view of target cells and fragmented RBCs, hemoglobin electrophoresis, Coombs test, and reticulocyte count can be suggested. Coming to the discussion part, the reason for discrepant platelet count is the platelet and RBCs are counted in the same chamber, RBC chamber, and the platelet is in the range of 2 to 20 femtoliter. So whatever RBCs which are smaller, microcytes and mini fragmented RBCs will be counted in the as platelets. What are the technologies methods for accurate assessment? Every smear in a platelet discrepancy have to be confirmed with a peripheral smear. Second is by immunoflow cytometry, and fluorescent labeling of the platelet RNA can be done. Coming to the clinical details, it was a 32-year-old female case of Hodgkin's lymphoma post chemotherapy. Last dose was 2 years ago, presenting with cytopenia. So cytopenia and dysgranulopoietic features may suggest the myelodysplastic neoplasm, and with this history of post chemotherapy, myeloid neoplasm post cytotoxic therapy can be suspected. And the further investigations can be bone marrow examination, cytogenetic evaluation including karyotyping, and next generation sequencing for myeloid neoplasm associated gene mutations. Second case, the clinical details is 16-year-old female presenting with anemia. On examination, splenomegaly and icterus noted. The cause of anemia. So the history, anemia, splenomegaly and icterus shows an extravascular hemolytic process, and it can lead to hemoglobinopathies. So the further investigations can be serum iron profile, reticulocyte count using a supravital stain and an automated cell counter, and a hemoglobin electrophoresis can be suggested. Thank you.
Dr. Leah, any reason for asking for reticulocyte count on supravital stain in the second case? Considering the morphology, yeah.
Supravital stain, if it's like alpha thalassemia HBH, or then the golf ball kind of beta tetramers will be deposit.
Sure. Thank you. I think you have made the job simpler. Let me just. Screen.
Entire screen. Select the screen. Share.
Yeah, thank you. It was a wonderful presentation. I think you got everything spot on. So let's go through that. So there were two cases which were given, and it was one was 32-year female and one was 16-year female, both with discrepant platelet counts. And this was the data provided. The initial run was 23,46,000, but initial she had a microcytic hypochromic anemia. And in the second run, when we used a different technology altogether, this was 33,000. So then we had to look at the histogram. If you can see this, since it's microcytes, it's completely shifted to the left as compared to the normal. And you have a lot of fragments. That's the reason it is almost going towards the zero, basically. And these have entered the platelet histogram, and that's the reason it's taking all those fragmented RBCs as platelets, and it's almost calculating the cells which have come till this particular line. So this is how a normal should be, but this is completely abnormal. So these were the questions we had asked. So we needed to choose these two. The RBC histogram is abnormal and platelet histogram is abnormal. And as Dr. Leah mentioned, this is definitely dyspoetic neutrophils. As you can see, there are no granules at all, which you can see. And but surprisingly, there were almost 50% of responses who had given this out as even normal neutrophils. I think my colleagues usually tell that to get used to digital morphology, it's slightly tougher. So I think since we are more used to digital pathology, we are able to appreciate this well. But definitely, if you look at even the lobations like this or this, and there's no granularity at all, this is definitely a dyspoetic neutrophil. And NRBCs were there, but there were also basophils and lymphocytes. You can consider these to be normal. So we needed you to choose neutrophils being abnormal or dyspoetic and basophils being there. But then this was the smear which we provided. And as you can see, there are a lot of fragmented RBCs. There is microcytosis, definitely, and there are poikilocytes. This may be because of the iron deficiency, is what we can consider. But these were the things which we had asked again. There were microcytic hypochromic RBCs. If you can see, the anisocytosis is up to moderate degree, and there were poikilocytes and fragmented RBCs and NRBCs being there. Now, with the impression, it's definitely a microcytic hypochromic anemia with thrombocytopenia. Now, anemia can be because of there may be a concurrent iron deficiency because we are speaking about a young female, and but in addition, there were these cytopenias, thrombocytopenia being there, and dyspoetic neutrophil. So whenever you have this, and there may be a possibility of MDS if this cytopenia is persistent. But then when we come to another very similar scenario of a 16-year-old, again the platelet count is much higher of 23 lakh 6,000. Now on a repeat run, again with a different technology, the platelet count were 2 lakh 67,000. And when you compare it with the normal, again the graph has shifted to left, but it's all the microcytes which are sitting, and that's giving this RBC such histogram or ragged appearance or so. And these fragments again have entered the platelet histogram, and that's where this histogram is becoming abnormal, and that is being counted as platelets. So again, in these two, we wanted you to choose these two options, which is abnormal RBC histogram and abnormal platelet histogram. And coming to the smear, if you can see, it's microcytic hypochromic was the indices, but then you have every possible shape of RBC. And if you can see, there are no NRBCs whatsoever in this particular smear. So whenever you have such severe looking, like a bad looking smear with no NRBCs, it is a HPH disease and nothing else. If you happen to have some amount of NRBCs, then we consider it to be a beta thal homozygous state. So in this particular thing, we wanted you to consider they're all microcytic hypochromic RBCs, anisocytosis being up to severe grade, which was not there in the previous case, poikilocytes being there, and NRBCs absent. So this should be the impression what you would want to consider while signing out the peripheral smear, which is hemolytic anemia, and you can be very certain that this is suggestive of a hemoglobinopathy. And you have to see whether there is splenomegaly, is there indirect bilirubin, and you can ask for further tests like electrophoresis and supravital stain, as Dr. Leah mentioned, to look for inclusions. And we came to the part two because we actually hit the history more because that's how we get samples. Like wherever you are reporting, you don't even get the history, you just get this is the age of the patient, there's the gender, and this is the CBC data. And that's the reason we actually had to split this into two different parts. So this was the second part where we asked so many questions about what may be the reason for discrepant platelet counts. Most of them had got it right. It was fragmented RBCs counted as platelets because the technology here which was used was impedance technology, which takes into account only the size of a particular cell. And then we had requested about what other methods would you actually use. Most of them again had got it right, but these were the things which we would want. Particle counting is more of your mere estimation based on the size. You can have optical counting, light scattering property that's available in a lot of cell counters. Fluorescence bind, dye binding, which again more of RNA based polymethane dye binding, which can be used, and immunoplatelet assay. So I think most of you had got it right. But then when we come to the clinical picture of this was post chemotherapy. So, since the last dose was 2 years ago, this cannot be just a chemotherapy induced cytopenias because it's a fresh cytopenia, and the dose of the last chemo was almost more than 2 years. So, with this, definitely there being cytopenias, you would think that there is ineffective hematopoiesis that is causing the cytopenias, and with the cytotoxic therapy being there, and there was dysplastic neutrophils in this particular patient, and this was myelodysplastic syndrome. So these were the further investigations which we had asked, and surprisingly, we had a lot of responses saying you have to do a Coombs test. Just to let you know, whenever you are speaking of a microcytic hypochromic anemia, your Coombs test should be never be in the list unless you have ruled out everything else. So that's one thing which we wanted to emphasize, because everyone had put it as direct Coombs test, indirect Coombs test, but no, we are speaking about a microcytic hypochromic anemia, and there your room to request for a Coombs is absolutely the last test you want to request. So in this particular patient, we would want you to request serum iron profile, reticulocyte count, either ways, just to look at how the marrow response is. Hemoglobin erythropoiesis, not much because we weren't seeing the poikilocytosis as much. Bone marrow examination, definitely, because we are looking at fresh cytopenias and dyspotic neutrophils, so we want to consider MDS to be a possibility. Cytogenetic evaluation, yes, to see what chromosomal abnormalities are there, and the NGS. When you come to the other case, which is 16-year-old, again, what is the probable cause? Again, here it is ineffective hematopoiesis, but it's because of a hemolytic process, and that's possible hemoglobinopathy as described, because we are looking at microcytic hypochromic anemia with such severe fragmented RBCs, with in addition you have splenomegaly and icterus. So again, in this, we would have requested for reticulocyte supravital stain, serum iron profile, yes, just because the anemia is too low. But you can almost skip this, because this particular case, because there is splenomegaly and icterus, this can be just a thalassemia intermedia phenotype. But yes, what we wanted you to request was through a supravital stain, automated cell counter, and hemoglobin electrophoresis. And this particular case, hemoglobin electrophoresis was done, and you have a fast moving hemoglobin band where HbH would elute, and on which, if you do a supravital stain, you get gauge polyclusions. So D4, the diagnosis, the first case we went ahead and requested for marrow. Marrow was done, and it was MDS. She had a TP53 mutation. Initially, there was a lot of ring sideroblasts when she was just MDS. Later, she progressed on to acute leukemia of erythroid differentiation. We didn't find the ring sideroblasts that time. But again, once therapy was started, the ring sideroblasts appeared. We don't know why it is, but we would request you to just keep this in thought and see why it could have happened. Ring sideroblasts being there when she was MDS and not there when she transformed to acute loop, and back when all the blasts reduced. And the second case was HPH disease. So, summary, whenever you have high platelet count, always analyze the histogram, because that will give a clue whether it's a true high count or not. But also look at the other cell counts. If you have persistent cytopenias which are there, then you know that is there another pathology, or all these are coming on to one single picture, as what how we saw in the first case basically. And why every investigation that needs to be recommended, that was the thing. So Coombs was requested, but whenever you have MHA, please make sure whom's will be your last investigation. So gratitude, and you can please write to us if anything, at least about the case where the MDS was there, which was ring sideroblast, which were there at diagnosis, disappeared, and then appeared again. So if you have any doubts also, you can please get back to me, and thank you. Any questions, any doubts? Or is there any discordance between what we have diagnosed and what you thought?
Thank you, Dr. Pradeep.
Yeah.
That was a very good session. Thanks a lot for all the PGs and all the delegates for joining us for these virtual sessions. With that, I would like to announce that the next slide seminar will be by Manipal Hospitals, Bangalore, and they will be uploading the slides very soon to the portal. And along with that, the information regarding the rest of the sessions for the entire year will also be put up in the next 1 week, including the allotment to the PGs. Thank you all for joining us. The certificates for the faculty as well as the PGs who present will be mailed to them in a day or two. Uh, Thank you all for joining us. That would be it. With that, we'll be closing the session. I thank Neuberg Anand Reference Laboratory for putting up such a good ensemble of cases for the PGs to learn. And I also would like to thank our sponsors, Sysmex and also OptraScan for scanning the digital slides for us. Thank you all for joining. Thank you, Dr. Padi.
Thank you.
With that, we close
Yeah.
the session.